Good afternoon. I'll be presenting a rare case of intraocular mass in an adolescent. So, a 13-year-old male boy presented to outpatient department with a history of diminution of vision in right eye for 2 months, and no other significant history was there. On examination, in right eye, vision was inaccurate projection of rays in 2 quadrants, and in posterior segment, exudative retinal detachment could be seen, and faintly pigmented mass was seen inferiorly in the vitreous cavity, and media was hazy. So, an ultrasound was performed, and a mushroom-shaped lesion with homogeneous moderate amplitude spike filling nearly the entire vitreous cavity with overlying retinal detachment was seen. Apical thickness of mass was 16.8 and largest basal diameter was around 13.5 as can be seen in this picture, and classic decrescendo sign is seen, and CMRI was observed, and T1 image showed brightly enhancing lesion and T2 image showed hypointense mass involving 2/3 of the globe reaching up to the posterior capsule of the lens. And a PET CT was done to rule out systemic metastasis. The differentials were thought of, it was quite a clear-cut diagnosis. However, the retinoblastoma is ruled out because of lack of calcification, unilateral presentation. Age was not typical. Metastasis were ruled out by PET CT. And for melanocytoma, the size of lesion was not in favor, and the lesion had low internal reflectivity, unlike melanocytoma. So, patient was diagnosed at right eye large choroidal melanoma with exudative retinal detachment T4A and planned for right eye enucleation under general anesthesia. Visual evoked response was done and no significant response was seen. And after written informed consent, it was enucleated with insertion of 20 mm PMMA implant, and enucleated globe was sent for histopathology. This is the intraoperative image showing the retinal vessels behind the lens. And histopathological section shows cornea, iris and melanotic tissue. And this is 20x image showing spindle cell melanoma with grade 1, grade G1 on histology. Why it was atypical? The age of presentation was very young. The median age for the tumor is around 6 decades, and it advanced quickly over 2 months. And also it was a posterior uveal melanoma. At this age, more of the iris tumors have been seen. And patient was doing well till last follow-up 6 weeks after surgery with prosthetic eye. So this is a paper which shows that less than 1% of uveal melanoma occur in young people, and overall incidence is just 4.3 per million. And it is observed that posterior uveal melanoma manifests preferentially during or after puberty, as also seen in our case. The child presented with just 2 months of diminution of vision. This could be associated with growth hormone spurt. So this is a study by Singh et al. Showing the incidence per million age-wise. And many studies have concluded that pediatric and adult melanoma are similar in prognosis or clinical appearance, and the treatment is essentially similar. And chromosomal mutations in young patients found that majority of these patients had disomy 3, and which is correlated with good survival outcome. Monosomy 3, 8q gain correspond to highest risk of metastasis. So, my take-home message is choroidal melanoma can present in young age and high clinical suspicion is needed. Thank you.
Abhijeet, excellent case. I have 2 questions for you here. I understand you have done a PET scan.
Yeah.
You did a PET scan to rule out systemic metastatic lesion. Did you have a FDG uptake in this lesion?
There was.
There was. So, right there you know that it was a choroidal melanoma, even clinically, even without histopathologically. A genetic testing was done in this case?
Sorry?
A genetic testing was done in this case?
H&D. Genetic.
Yeah. Genetic.
No, not in this case. The patient was not affording.
Not affordable. Okay, all right. Because he's very young, and it's good to know, because we all know that prognosis of choroidal melanoma also depends upon the size of the lesion, apart from the genetic markers, right? So there is this atlas which has come up where there are so many criterias, not only the size, but the mutations which is involved, But if patient cannot afford, maybe you can go in for some study or request some, MedGenome does it. If it's a very rare case, MedGenome is a company who does genetic testing. They do it free of cost. Even if you have your specimen available with your pathologist, you can still do it. You can actually do an MLPA, take out RNA and DNA from the same specimen, even a fixed specimen.
It will be good
to MedGenome, MEDGENOME. They actually, rare cases, they would definitely do it free of cost. So you can just write it to them. I can give you the mail ID, and it's good to know that because he's such a young patient,
Yeah.
and he has so many years in front of him to live. So it's good to know what the tumor is. Thank you so
Thank you.
much. Yeah.